Welcome to Dr. Balga's podcast for the Curious Doc. Today is January 27, 2026. This video is on a paper published in circulation 6 days ago on 21st January 2026. It's the annual 2026 Heart Disease and Stroke Statistics, a report of US and global data from the American Heart Association. What is AHA's statistics update? It's the American Heart Association's annual compilation of most up-to-date statistics in heart disease, stroke, cardiovascular risk factors, major cardiovascular conditions and outcomes, such as quality of care, procedures, and costs. What's life's essential 8? A cardiovascular health construct in 8 key areas: smoking status, physical activity, weight, diet, sleep, blood glucose, cholesterol, and blood pressure. How is Life's Essential 8 different from Life's Simple 7? Life's Essential 8 updates scoring for the original 7 components and adds sleep health. Why is CKM health, or cardiac, kidney, and metabolic health, and why is it included? What is it? CKM stands for cardiovascular, kidney, metabolic health. It expands cardiovascular health by explicitly incorporating kidney health and describes CKM syndromes as stages 0 to 4, progressing from optimal CKM health to prevalent CVD. What's new in the 2026 edition? It adds a new chapter on cardiovascular, kidney, metabolic syndrome and expands the tobacco and nicotine chapter. By 2050, what does the AHA project for hypertension prevalence among US adults? From 51.2% to 61%. By 2050, what does the AHA project for diabetes prevalence among US adults? From 16.3% to 26.8%. By 2050, what does the AHA project for obesity prevalence among US adults? From 43.1% to 60.6%. Which health factor is projected to decline by 2050? Hypercholesteremia, from 45.8% to 24%. What happens to smoking prevalence in AHA projection? Current smoking is projected to decline from 15.8% to 8.4%. What happens to inadequate physical activity in AHA projection? Inadequate physical activity is projected to decline from 33.5% to 24.4%. What happens to inadequate sleep in AHA projection? It's projected to increase from 40.3% to 42.1%. How strongly is ideal cardiovascular health linked to fewer cardiovascular disease events? A meta-analysis of 59 longitudinal studies from 2010 to 2022 reported 74% lower risk of cardiovascular disease events for ideal versus poor cardiovascular health. How is cardiovascular health connected to brain health in this update? Better cardiovascular health, Life's Simple 7 and Life's Essential 8, is associated with younger brain age, less subclinical vascular disease, slower cognitive decline, and reduced dementia risk. How important is tobacco use as a risk factor in the US? It's stated as the second leading risk factor for death in the US. What is the mortality impact of smoking? People who smoke are reported to have 3 times higher mortality than people who don't smoke or never smoked. How did adult cigarette smoking change from 2017 to 2023? It's reduced from 10.8% to 7.9%. How did adult e-cigarette change from 2017 to 2023? It's increased from 1.2% to 4.1%. In 2024, how common was youth ever use of any tobacco product? 1 in 4 high school students, that's about 3.7 million, and 1 in 8 middle school students, 1.53 million. In 2024, how common youth ever use of e-cigarettes? 8.5% of middle school adults, that's about 1 million, and 18.1% of high school adults, that's about 2.84 million. How many youths meet daily activity of greater than 60 minutes every day? Only 1 in 5. These are youths between the age of 6 to 17 years. How do activity rates differ by age in youth? 25.6% for ages 6 to 11 versus 13.7% for ages 12 to 17. How do activity rates differ by sex in youth? 22.6% for males versus 16.2% for females. Globally, what fraction of adults have insufficient physical activity? An estimated 31.3%, that's about 1 in 3, across 5.7 million participants in 163 countries, are defined as not meeting WHO guidelines, that is, greater than 150 minutes per week of moderate intensity or equivalent of exercise. What did the Women's Health Study show about steps and mortality? In a study cohort of 14,299, mean age 71.8, each standard deviation increase in accelerometer measured steps per day was associated with lower all-cause mortality and cardiovascular disease mortality. These models are adjusted for demographics and lifestyle behaviors. Which life's essential 8 metric scores lowest overall? Diet is described as the lowest scoring life's essential 8 metric. What diet scores in adults? What are diet scores in adults? Adult diet scores range 23.8 to 47.7 out of 100 depending on the demographic group. What are diet scores in children? 61.1% in children 2 to 5 and 28.5% in children 12 to 19. What did product prescription programs show? Across 22 programs and 3,081 participants, after median 6 months, adults increased fruit and vegetable intake by 0.85 cups per day and children by 0.26 cups per day. How common is sleep debt in US adults? The NIH study showed 30.5% had greater than 1 hour sleep debt, 9.7.5 had 2 hours of sleep debt. That's high sleep debt. What did the Spanish worker cohort show about poor sleep and cardiometabolic risk? In over 500,000 workers, poor sleep was associated with higher odds of high blood pressure, type 2 diabetes, hypercholesteremia, obesity, and physical inactivity. What did UK Biobank show about improving sleep over time and cardiovascular disease? Compared with stable poor sleep, stable healthy sleep, and improved sleep over 9 years was associated with lower cardiovascular disease risk. What is the global burden of disease US obesity forecasting collaborators estimate for 2021 for the US? Overweight or obesity affected 15.1 million children, 21.4 million adolescents or young adults, and 172 million adults, that is above the age of 25. How was global burden attributable to high BMI changed? How has the global burden attributable to high BMI changed? Global deaths and DALYs attributable to BMI greater than 25 increased greater than 2.5-fold for females and males. What is the stated potential economic impact of elevated BMI by 2035? Up to 4.32 trillion annually. How did the prevalence of high cholesterol change in US adults? High total cholesterol greater than 240 milligrams per deciliter decreased from 18.3% to 11% with no significant change thereafter. What happened to high blood pressure control in recent years? Hypertension prevalence stayed 32%, but blood pressure control declined 54.1% to 48.3% among black adults. Control improved from 37.4 to 49.6% for those with hypertension and from 52.6 to 62.6 for those on antihypertensives. What prescribing disparities are noted in the NIH All of Us study? White participants started blood pressure meds at lower systolic blood pressure, around 130.9 millimeters of mercury, than blacks who started at 136 millimeters, and Hispanic adults at 136.3. 60.5% of black individuals received guideline recommended meds versus 73.8% of white and 81.3% of Hispanic individuals. What are the most recent diabetes prevalence figures cited? Diagnosed diabetes, 29.5 million adults, that's 10.6% of the population. Undiagnosed diabetes, 9.6 million, that's about 3.5%. Pre-diabetes, 96 million, 37.2%. Adolescents between the age of 12 to 17, around 8.4 million, that is 32.7, are estimated to have pre-diabetes among adolescents. What trends were cited for glycemic control among adults and diabetes? Mean hemoglobin A1C increased 7.31% to 7.6%, while glycemic control declined from 54.3% to 43.5%. What is the purpose of annual AHA statistics update? To compile the most current US and global data on cardiovascular disease, stroke, and risk factors into one single paper or reference. What data sources are most commonly used? Major sources include the NHANES NHIS database, the CDC's NVSS Wonder database, HCUP, GWTG registries, USRDS, and the Global Burden of Disease GBD study. What's the difference between prevalence and incidence? Prevalence is how many people have a condition. Incidence is how many new cases occur over a period. Why does the report emphasize age-adjusted rates? Age adjustment enables fair comparisons across groups and over time when population age structures differ. Why are trends sometimes difficult to interpret? Because estimates may use different surveys, different coding systems, for example ICD-9 versus ICD-10, and changing population denominators. What is Life's Essential 8? AHA's updated cardiovascular health construct, which includes diet, physical activity, nicotine exposure, sleep, BMI, blood lipids, blood glucose, and blood pressure. Why was sleep added? Because sleep is independently linked to cardiometabolic outcomes and improves risk discrimination for cardiovascular health. How strongly is ideal cardiovascular health associated with outcomes? Meta-analysis data summarized in this report notes there is markedly lower cardiovascular disease risk for ideal versus poor cardiovascular health. What is CKM health and why does it matter? CKM integrates cardiovascular, kidney, and metabolic health, capturing a continuum from optimal health to established cardiovascular disease. What's the big message of the CVS chapter of this book? Improving composite cardiovascular health shifts risk for cardiovascular disease, brain health outcomes, and mortality, population-wide and equitably. Tobacco and nicotine use and exposure. Why does the report broaden from smoking to tobacco and nicotine? Because modern exposure includes e-cigarettes, dual use, and second-hand aerosol, each with distinct patterns and risks. What are the key surveillance systems used? NHIS for adult use patterns and NYTS for youth tobacco product use. What is the clinical relevance of rising e-cigarette use? It changes nicotine exposure trajectories, especially in youth, potentially reshaping future cardiovascular disease burden. How should clinicians frame risk when patients ask about vaping? Emphasize nicotine dependence, exposure uncertainty, and the importance of complete cessation while tailoring to patient context. What equity issue is central here? Exposure and cessation success differ by socio-demographic factors and marketing environments, affecting downstream cardiovascular disease risk. Physical activity and sedentary behavior. Why does this chapter track both activity and sedentary time? Because inactivity and prolonged sitting can confer risk even among people who exercise. What benchmark is commonly used internationally? The WHO guidance equal to or greater than 150 minutes per week of moderate intensity activity or equivalent. Why are step-based metrics highlighted? Because accelerometer-based steps correlate with mortality outcomes and may be more intuitive for public guidance. What's the key youth concern? Few youths achieve greater than 60 minutes of daily activity, with declines in adolescence. What practical takeaway fits primary care? Move more, sit less, and measure it. Small increases can be meaningful at a scale. One can argue atomic habits for exercise may be the way forward. Nutrition. Why is diet called the lowest scoring life's essential 8 metric? Because population level diet quality remains poor across many demographic strata. What types of diet measures are commonly used? Indices such as HEI, AHEI, Mediterranean patterns, and plant-forward scoring approaches. What are product prescription programs? Programs that provide subsidized fruits and vegetables to improve intake and cardiometabolic risk factors. What is the signal across dietary patterns? Higher adherence to healthy eating patterns is consistently elevated with lower cardiovascular disease risk. What is the main limitation of nutrition epidemiology? Measurement error, self-reporting, confounding, and cultural variability in defining healthy patterns. General limitation. See the nutrition methods discussion across epidemiology texts, not uniquely specified in the excerpt. Sleep health. What is sleep debt in population surveys? It's the difference between sleep duration on work days versus free days, used as a proxy for chronic short sleep. Why does sleep matter for cardiovascular disease risk? Poor sleep is associated with high blood pressure, diabetes, dyslipidemia, obesity, and inactivity. What is the key longitudinal concept? Improving sleep trajectories over years is associated with lower cardiovascular disease risk compared with stable poor sleep. How should clinicians operationalize sleep in prevention? Treat sleep as a vital behavior, screen for quality and duration, and evaluate sleep disorders when indicated. What's the trap to avoid? Assuming more is always better. Both short and long sleep can be associated with higher risk. High blood cholesterol and other lipids. What lipid measures are most highlighted? Total cholesterol, LDL cholesterol, and increasing attention to non-HDL and other lipid fractions. Why is LDL cholesterol emphasized globally? The global burden of disease attribution ties elevated LDL cholesterol to substantial cardiovascular disease mortality worldwide. What is the reported US trend? High total cholesterol prevalence fell from 1999 to 2000 to 2013 to 2014 and then plateaued. What's the clinical takeaway? Population lipid trends improve slowly. Individual risk reduction still hinges on guideline-directed therapy. Why mention other lipids? Because triglycerides, Lp(a), and other markers might help refine risk in selected patients. High blood pressure. Why can prevalence be stable while control worsens? Because treatment uptake, adherence access, and clinical inertia can shift even when prevalence does not. What disparities are emphasized? Difference in treatment thresholds and receipt of guideline-recommended medications by race and ethnicity. What does the report say about alcohol? The risk of high blood pressure rises with increasing alcohol exposure, with gender-specific patterns. Why does measurement matter in population blood pressure stats? NHANES include measured blood pressure, not only self-report, thereby improving validity. What's the boring but lethal message? Blood pressure control is a systems problem masquerading as an individual problem. Diabetes. Why distinguish diagnosed from undiagnosed diabetes? Undiagnosed diabetes contributes to delayed risk reduction and complications. Why include pre-diabetes statistics? Because pre-diabetes prevalence signals future diabetes and chronic and cardiac kidney metabolic progression, CKM progression. What is a key recent US trend? Worsening glycemic control, higher mean hemoglobin A1C, lower proportion of the population is controlled in recent enhanced comparisons. What's the youth relevance? High estimated prevalence of prediabetes among adolescents implies earlier lifetime exposure to risk. How should clinicians integrate these data? Aggressively address cardiometabolic risk factors alongside glycemia. Diabetes care is cardiovascular disease care. Cardiovascular kidney metabolic syndrome. What is CKM syndrome? A stage framework 0 to 4 describing progression from optimal CKM health to advanced disease and prevalent cardiovascular disease. Why is staging useful? It links prevention targets to a biological continuum and supports risk communication. What population patterns are highlighted? Stage distribution varies by age and socio-demographic group. Advanced stages are more common in older adults. What outcome association is emphasized? More advanced CKM stages associate with higher cardiovascular disease mortality, with gender differences reported. What is the clinical translation? Stop thinking in silos. Blood pressure, glucose, weight, and kidney function are one orchestra and not four soloists. Adverse pregnancy outcomes. What counts as adverse pregnancy outcomes here, or APOs? Examples include gestational diabetes, hypertensive disorders of pregnancy, preterm birth, low birth weight, and small for gestational age. What are APOs in cardiovascular disease statistics report? They are early life stress tests predicting future cardiometabolic disease risk. What preventive theme is emphasized? Pre-pregnancy lifestyle factors associate with lower APO risk in cohort data. What intervention is mentioned? Metformin trials show reduced risk of hypertensive disorders of pregnancy in meta-analysis. Key equity point: maternal mortality differs substantially across racial and ethnic groups. Total cardiovascular diseases. What's included in the total cardiovascular disease prevalence in this report? Typically high blood pressure, coronary artery disease, stroke, and heart failure, with definitions based on ICD codes for other sections. Why present cardiovascular disease excluding hypertension? Because hypertension is common and can dominate prevalence. Exclusion helps interpret clinical disease burden. What's the value of ICU registry data? It characterizes severe presentations, example cardiogenic shock, and care patterns in contemporary practice. How does diet fit here? Healthy eating patterns consistently associate with lower cardiovascular disease risk across large cohorts. What is the systems question data in this chapter answers? How big is the problem and how it changes across age and sex groups? Stroke. What major stroke subtypes are considered? Ischemic stroke, intracerebral hemorrhage, and subarachnoid hemorrhage. What does the chapter emphasize about disparities? Stroke incidence rates are persistently higher in Black adults with age-specific differences. What therapy trend is highlighted? GLP-1 receptor agonists show stroke risk reduction in meta-analysis of type 2 diabetes trials. Why track case fatality? because it reflects acute care effectiveness, subtype distribution, and survivorship patterns. Key clinical takeaway: prevention is the best stroke unit. Control blood pressure, diabetes, and vascular risk early. Brain health. Why is brain health in heart disease statistics report? Vascular risk factors strongly influence cognitive decline and dementia risk. What population trend is noted? Declines in dementia prevalence in older US adults across NHAT survey years. How does global disease burden of disease inform brain health? Global burden of disease study tracks dementia burden globally and over time and across age strata. What role does exercise play? Trials meta-analysis suggest higher intensity exercise may improve or slow cognitive decline. The practical message: protect the brain by managing vascular risk. Neurons prefer good perfusion and low drama. Congenital cardiovascular defects and Kawasaki disease. Why combine congenital defects and Kawasaki disease? Both are major pediatric cardiovascular conditions with lifelong implications. What trend drives adult congenital care? Improved survival into childhood increases adult prevalence and healthcare needs. Why emphasize where a child lives? Neighborhood factors like poverty, pollution, prenatal access relate to risk, diagnosis timing, and outcomes. What is the key service implication? Transition of care systems are essential as pediatric congenital heart disease becomes adult congenital heart disease. What's the clinician's takeaway? Plan for a lifespan, not a childhood. When counseling congenital heart disease families. Disorders of heart rhythm. Which rhythm disorder dominates public health burden? Atrial fibrillation is highlighted as common and increasing. Why are lifetime risk estimates relevant? They capture how aging populations translate into future AFib burden. What lifestyle exposure is emphasized? High sodium intake is associated with higher AFib risk in cohorts. Why does AF matter beyond palpitations? Because it's a key driver of stroke and heart failure outcomes. Clinical takeaway: atrial fibrillation is often the rhythm of risk factors. Treat upstream drivers, not only the EKG or the ECG. Sudden cardiac arrest, ventricular arrhythmias, and inherited channelopathies. Why is out-of-hospital cardiac arrest surveillance hard? Because ascertainment varies by EMS, emergency medical systems, and registries. Standardized reporting is crucial. What emerging contributor is emphasized? Opioid-associated out-of-hospital cardiac arrest has increased markedly in recent years. Why distinguish reversible ischemic causes? Because prognosis and long-term outcomes differ compared with non-ischemic causes. What equity signal appears? Differences in in-hospital cardiac arrest survival by race and ethnicity are reported in registry analyses. Where do inherited channelopathies fit? They explain a subset of ventricular arrhythmias and sudden death, often in younger individuals. Subclinical atherosclerosis. What is subclinical atherosclerosis? Atherosclerosis is detected before symptoms via coronary artery calcium, carotid IMTs, or plaque imaging. Why is incidental coronary artery calcium reporting a problem? Because underreporting misses prevention opportunities when calcium arteries calcification is found on non-cardiac CT scans. How does AI enter this chapter? AI algorithms can quantify coronary artery calcium and link burden to downstream risk estimates. What is the clinical implication of coronary artery calcium-informed prevention? Coronary artery calcium can reclassify risk and intensify prevention strategies for appropriate patients. What is the prevention punchline? Plaque whispers before it screams. Listen early. coronary artery disease, acute coronary syndrome, and angina. What does coronary artery disease prevalence represent in the NAINS database? Self-reported physician-diagnosed coronary artery disease MI angina constructs depending on survey definitions. Why discuss intravascular imaging trends? Because IVIS and optical coherence tomography use has expanded and is associated with better procedural outcomes in observational data. What is cardiac tele-rehab? Remote rehab delivery, often comparable to center-based programs in effectiveness and adherence. Why keep angina in the statistics report? Because it reflects symptomatic ischemia burden and care patterns beyond myocardial infarction. Key clinical takeaway: modern coronary artery heart disease is not just stents, it's systems, adherence, and rehab. Cardiomyopathy and heart failure. Why group cardiomyopathy and heart failure? Because cardiomyopathies are major etiologic pathways into heart failure syndromes. What trends are emphasized? Rising heart failure prevalence estimates and substantial heart failure attributable mortality burden. Why do EHR-based prevalence estimates matter? They provide contemporary large-scale estimates but depend on coding accuracy and capture. What's the key clinical message? Heart failure is common, lethal, and expensive. Prevention and guideline-directed medical therapies remain the core. What is the numbers meet nuance caution? Heart failure definitions vary across datasets. The trends must be interpreted within methods. Valvular disease. Why separate rheumatic versus non-rheumatic valve disease? Because epidemiology, geography, prevention, and treatment differ substantially. What procedural trend is highlighted? TAVR volumes increased and exceeded surgical AVR after low-risk approvals expanded eligibility. Why does this matter for workforce planning? TAVR expansion shifts procedural mix, follow-up needs, and imaging demand. What global burden is emphasized? Large numbers live with rheumatic heart disease and calcific aortic and mitral disease worldwide. Clinical takeaway: valve disease is increasingly treatable, but the world still needs prevention. Venous thromboembolism, chronic venous insufficiency, and pulmonary hypertension. Why group these conditions? They share thromboembolic and venous hemodynamic pathways and overlapping care systems. What mortality trend is noted for PE in younger adults? An increasing age-adjusted mortality rate in US young adults over time. How does cancer intersect with venous thromboembolism? Cancer-associated thrombosis incidence varies markedly by cancer type and time course. Why is pregnancy addressed? Pregnancy and postpartum pulmonary embolism remain critical, trackable causes of maternal morbidity and mortality. Where does pulmonary hypertension fit? It's included as major vascular disease burden category in outcomes and registries. Peripheral artery disease and aortic disease. Why is PAD underdiagnosed? Symptoms are atypical, ABI screening and risk recognition are inconsistent. How does AI show up in PAD? Waveform AI analysis can stratify long-term risk in PAD cohorts. What's a key implementation focus? Team-based vascular care models and improving lipid goal attainment. Why mention Lp(a)? Very high Lp(a) is associated with higher PAD risk in large cohorts. Key clinical takeaway: PAD is systemic atherosclerosis. Until proven otherwise, treat risk aggressively. Quality of care. What does quality of care mean in this report? Measures of evidence-based treatment, disparities, outcomes, and system performance for cardiovascular disease and stroke. Why are projections included? To inform planning, future prevalence, and cost depend on present prevention and care quality. What disparity example is highlighted? Difference in rates of aortic valve replacement across racial and ethnic groups in Medicare cohorts. Why discuss cost transparency? Because medication cost discussions can change decision making and adherence planning. Takeaway: quality is the bridge between guidelines and outcomes. Without it, data are just statistics in formal wear. Cardiovascular procedures: why track procedures annually? Procedural volume reflects disease burden, technology diffusion, and health system capacity. Which procedure is most common in the US in 2022? PCI is cited as the most common cardiovascular procedure. Why highlight TAVR volume and site counts? It indicates rapid national adoption and informs access and outcomes research. Why include transplant statistics? They reflect end-stage disease burden and regional variation in advanced therapies. Clinical takeaway: procedures are a visible tip of a prevention iceberg. More risk lives below the waterline. Economic costs of cardiovascular disease: what costs are included? Direct medical costs and indirect costs, example productivity losses estimated nationally. Why report costs over multi-year windows? Because cost estimation often relies on food survey and expenditure data sets and improves stability. What's the macro level message? Cardiovascular disease imposes enormous national economic burden, hundreds of billions annually in recent estimates. Why break down hypertension costs? Hypertension is prevalent and costly. Identifying drivers, including medications, visits, and hospitalizations, inform interventions. Policy takeaway: prevention is not only humane, it's budgetary cardiology. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.